All right. So the exemplar diabetes mellitus, the concept, glucose regulation is what you guys are talking about this week, as well as acid-base balance. I had a video already posted on acid-base balance or imbalances. So that being said, I wanted to talk to you a little bit about diabetes mellitus. As I go through the book, I want you to make sure you review the pathophys behind it. And real brief, as you can see, this here are your interrelated concepts, and they're important to know because obviously a lot of these things impact our patients with diabetes. Acid-base imbalances, you'll find out we have fluid and electrolyte problems with osmolarity, they have immunity problems, they have sensory problems, tissue integrity, and then nutrition problems. So these are all interrelated concepts that you have to focus on when we're talking about this. This is just insulin. So as you know, the feedback loop with insulin, I go through this pretty quick. There's glucose floating around in your body and it signals the pancreas to secrete insulin, correct? What does that do? Insulin is the key to get glucose either stored in the liver, utilized for energy, utilized for skeletal muscle, stored in fat. So, or like I said, stored in the liver. It's that key mechanism, that locking key. But what insulin also does is when that key mechanism goes in there, it's the transporter that's on that receptor. It's the only way that it can be stored or utilized, correct, into these sites, liver, fat, skeletal muscle. It can get into the brain without insulin, okay? But that being said, it also is a key to, it needs a receptor, and it goes onto that receptor and it gets dragged through with something called GLUT, it's glucose uptake transporter. At the same time, that allows potassium, phosphorus, and magnesium to move into the cell as well. So it doesn't, it pushes it, it helps push it into the cell. Then once your glucose level is down, that feedback loop tells the pancreas to stop producing insulin. Okay, this is what insulin does in your normal, healthy individual, right? It's a negative feedback loop. So with type 2 diabetes, you have a lot of glucose floating around. The pancreas secretes the insulin, correct? But there's what's called insulin resistance, can be called. That receptor is resistant, malfunctioning over either from overuse, overproduction of hyperinsulinemia or anything else. It doesn't have that uptake, that ability to be stored in the liver for future use often. And you end up having like glucosuria, glucose that is, we used to call it spilled out, but urinated, voided out through vice to your kidney, right? We have polyuria, a lot of urine, because with glucose, the water is going as well. In addition, polydipsia, the brain has this desire for thirst because you're urinating a lot, correct? And then you have polyphagia, right? Because it's not converted to energy in the cell. So there's a lot of hunger. You have a lot, you can have muscle wasting as well, but polyphagia, they're hungry, okay? So you end up having beta cell atrophy because either from overproduction of the pancreas of beta cells, of insulin from the beta cells, which isn't being utilized, then you end up with some beta cell atrophy. If you really want to look into it, there's quite a bit of information. The book goes into proinsulin. It's broken down into 3 different types of chains, okay? And really what that will tell you is it's a way of measuring the amount of insulin that might be in the body, okay? So we have increased glucose production. So the difference though is you have residual insulin, but you don't, because you have that residual insulin that is too as well, you don't have those, you have no ketones, so you're not muscle wasting per se. But you have a high serum glucose, hyperglycemia, so you have that serum osmolality that's just high as well. You're a hyperosmolar. That's hence where this HHS comes from, hyperglycemic hyperosmolar syndrome. or state, depends on what you say. With that loss of electrolytes and water with the urine, as you can see, you have dehydration. HHS is typically a manifestation of type 2 diabetes that's either poorly controlled diabetes or a manifestation or a state from infection. Someone's sick, they didn't know they had diabetes on it, honestly, until this symptoms came on. It's not a fast acting response. It takes a while. It occurs over time, but they have the signs and symptoms: polydipsia, polyphagia, polyuria, right? They're dehydrated. They have a loss of electrolytes. Then they have that hyperglycemia, hyperosmolar state, right? Look at your osmolality of your blood. And in the end, they can end up in coma. That's very late. They can become unconscious. They have very high glucose levels. They can become hypotensive and tachycardia. Tachycardia because they're hyperosmolar, right? They're dehydrated intravascularly. And it's very, the elderly, they're much more sensitive to this than the younger adult population. So they just don't have the residual. When you look at type 1 diabetes, what is it? It's a lack of insulin production from the beta cells, right? You have your islet Langerhans that have these beta cells, and it takes time as well. It's not an overnight, like hypoglycemia, which happens like that really fast. Type 1 diabetes takes a while too, years. And that's why it's normally diagnosed by around the age of 12 to 14. Okay, it can occur later on in life too from environmental hazards, damage, radiation, tumors, things like that are exogenous. But as you can see, there's this macrophage that attacks the islet or Langerhans, the beta cells, and so they stop producing insulin. So they have no insulin. They have zero insulin. So it can be caused by genetics and family, location, and age. But it too is an emergent complication. So the emergent complication of type 1 diabetes, once they're diagnosed, they have the same symptoms, right? They have polyuria, polydipsia, polyphagia, but they have lack of insulin. They have no insulin. So their body is not able to store glucose when they need glucose. So glucose is just floating around in the body is the best way to think about it. It has no ability. It does not have that insulin to lock and key it and either utilize it in the skeletal muscle or store it in the liver or the fat cells. So it's just floating around. So you have glucose floating around in the body, but your body still needs energy of some form, right? So they have skeletal tissue breakdown. And that's where this ketone process is. They're proteins that are broken down. Skeletal muscle, fats are broken down, lipolysis, proteins are broken down, and you have muscle wasting. That's where the term diabetic ketoacidosis comes from, DKA. Both of these are hyperglycemic states. Type 1 diabetes doesn't typically have as high of a glucose level as type 2 diabetes, HHS. They both have the same symptomatology. Now, what you'll see different in type 1 and type 2 diagnostically is you'll have a patient that has what's called Kussmaul's respirations. Kussmaul's respirations it's a tachypnea, but it's involuntary. It's the body's compensating to blow off what? CO2, as you just learned. So it's blowing off CO2 because they're in an acidotic state. Diabetic ketoacidosis is the term. Metabolic acidosis. So they have the ketones in there. So you won't find Kussmaul's respirations, nor will you find ketones in HHS. DK clinical manifestations are very similar. Well, except for you have this fat breakdown, ketone body production, and you have ketosis. There's your other manifestations that you have are Kussmaul's respirations, and they have a metabolic acid. They're in a metabolic acidotic state. The triad of DKA, hyperglycemia, ketosis, and metabolic acidosis. We're not going to go into treatments. I'm going to skip through this. Don't worry about this. But this is important, macrovascular. It's in your book. Obviously, you must know the difference in the two. Microvascular disease processes versus macrovascular. Also look at microvascular, and a lot of patients aren't even diagnosed with type 2 diabetes until they start to have symptomatology, and symptomatology typically occurs after about 10 years of having the disease, but they go undiagnosed, right? Vascular changes from diabetes. I'm trying to skip through most of this. Okay. Hemoglobin A1C, you must understand. Remember, it's the saturation of glucose that's on the life of the red blood cell. That glucose is bound to that red blood cell, and its affinity does not release it. So, but you do fasting plasma, FPGs, oral OGTTs, oral glucose tolerance tests. You can look at islet cell antibodies, autoantibodies to insulin. Let's see, don't worry so much about GAD65, and then there's C-peptide. And that C-peptide is really how insulin is produced. And that C-peptide, it's where it's cleaved off. And if you have a lot of C-peptide, that means you're in a hyperinsulinemic state, meaning they're making a lot of insulin, but yet it's not functioning effectively. It's ineffective. So you're going to monitor all those things on the right. Okay. Microalbumin in the urine is a sign of what? Early onset what? Kidney disease, kidney problems, kidney failure due to macrovascular disease processes. So lipid panel in the book, which this presentation doesn't have, you have to know the difference in pre-diabetes, diabetes, and also your metabolic syndrome. So I would draw a table similar to something like this to metabolic syndrome, pre-diabetes and diabetes, and then type right out what your fasting plasma glucose would look like. What are some other indicators, HDLs, what are the waist circumferences, things like that, that will help you differentiate between the three. So know these, know the onset, the peak, onset, and duration of these 4 different types of insulins. I would know the top one on each one of them at least. Okay. Your oral antidiabetic agents as well. So the patients that get admitted to the hospital that have type 2 diabetes that are only on oral antidiabetic medications will be put on injectables. This came from Giddens. Our ranges are a little bit different, but this is what's so key is signs and symptoms. You have to know the difference. Okay, these are the 3 Ps. There's even more than that if you think about it. Polydipsia, polyuria, polyphagia, hunger, that's polyphagia, poor wound healing, phusmosis, DKA, fruity odor of the breath, DKA, fatigue, they're exhausted, they have weight loss. Okay, whereas signs and symptoms of hypoglycemia, which you need to be able to recognize like this, diaphoresis, tremors, cognition changes. Anybody with cognition changes, changes in cognition is not a normal sign and symptom for anything other than something's going wrong. Okay. Know the difference. You have to be able to identify the cues. What can cause hypoglycemia? All these. Okay. Meds. Exogenous insulin. We give them too much, or in their NPO, or we give it in their NPO, or we give it and they get sick and they start vomiting and they don't eat. Okay. Lack of food, like I said, too much exercise. You'll see it with like marathon runners. Okay, and alcohol. Drink instead of eat. Prevention and treatment of hypoglycemia. I would know the 15 grams of carbohydrates, right? When do you give it? A lot of times when, okay. I want you to look it up and review when you would go with oral versus IV, IM replacement for somebody who is in hypoglycemic state. Okay. Right here, it says if the person's unconscious, administer glucagon. Okay. But you must be able to identify the patients that are at risk and be able to look at the cues and put everything together and backward track. So if you know you gave medications in the evening for whatever reason, you knew the night shift nurse gave insulin glargine, and it's the next morning and your patient's vomiting and not taking any part of their meal tray, you will want to at least evaluate that patient within a certain duration based off the peak, the onset, the duration of that insulin that was given, and potentially have to give them IV dextrose, okay, or just supplement them intravenously, okay, vice hanging IV fluids. A lot of times you're going to have a diabetic patient in the hospital that's not there because of diabetes. They're there for a surgery. They're there for pneumonia. They're there for a COPD exacerbation. They have like secondary, they have diagnosis of diabetes. So you have to manage that. And that's what med-surg nursing is all about, is being able to manage multiple disciplines, multiple medical diagnoses of one patient, right? So stress, infection, just change in food intake, all those impact a patient who has diabetes. Okay? Think of go back to catecholamines, what's being released during stress. Hyperglycemia. What medications can we give that cause hyperglycemia? Steroids, right? So ineffective health management, we like to call that, sometimes it's non-compliance, you know, so here are just complications. So these are all of them: stroke, hypertension, atherosclerosis. These are your microvascular and macrovascular disease processes, okay? Checking your feet for this, teaching the patient to check their feet, right? Because they have a lack of sensation. They have neuropathies, or they have decreased sensation, okay? With atherosclerosis and decreased blood flow, they're at greater risk of both infection, delayed wound healing, poor wound healing, and lack of oxygen delivery. So these patients often start by losing a toe, and then it starts to migrate up half a foot, to the ankle, to the below the knee. Collaborative problems, these are that they're at risk for. Prevention. In hospital preferred treatments. Optimal blood glucose control is important, okay? Absence affection, improving wound healing for the surgical patients. This is directly from your book, okay? How do we prevent this? How do we prevent DKA? So whether it's from environment, infection, emotional stressors, you have a lack of insulin, okay? What happens, the body needs, right? In the presence of mild, moderate, or severe dehydration, which is going to be here with electrolyte balance. But that being said, you have a lack of insulin. So you have breakdown of fat in the cells, okay? You have free fatty acids that go to the liver. That's where the formation of your ketone bodies come from. And they end up with ketones in their urine in an acidotic state. So with the lack of insulin, they have a breakdown of glycogen into glucose, anything that might have been stored. And they have hyperglycemia, osmotic diuresis, right? Then they become dehydrated, they become hyperosmolar and hemoconcentrated. So despite what they're orally taking in and eating, your body's unable to utilize it. So it's just floating around because they do not have insulin which is the receptor that needs insulin as its key to take the glucose out of the bloodstream and store it into, or utilize it in the muscles, stored in the liver, or stored in fat cells. Okay. Same thing here, and then they have protein breakdown. They were increased BUN, hyperglycemia. They have increased potassium, all right. Initially, it's mild, and then they have a decreased potassium as well. That can be severe. So potassium's key can be floating around in the bloodstream as well because it's unable to get stored inside the cells because of the lack of insulin. Then once we give insulin, but that's next semester, so don't worry about it, sorry. How to prevent HHS, not preventing it, but this is our goal, right? We have a decreased amount of insulin as well. Okay, but typically these are patients that they have insulin, but they are insulin resistant, okay? So same thing happens, all right? They have a breakdown of glycogen into glucose. They end up hyperglycemic. They have an osmotic diuresis as well. And then they are extracellular, they're dehydrated. They have kidney impairment. They have severe hyperosmolality because of the high levels of glucose in them. And they have intracellular dehydration, which is why as the elderly clients who already are hemoconcentrated often, they don't have the same oral intake, they don't have the same thirst drive as the younger adults. They are at greater risk. So, little breakdown of fat in the cells. They have some free fatty acids. Okay, they don't have ketone bodies. You won't see that they do on any exam. What is the difference? They do not have ketones and they are not in an acidotic state. Here's how often these, standards of care are desired results and for labs, clinical measures, frequencies, and everything else. Okay, we have to teach patients. When was the last time you had an eye exam? All right. Assess, right? This is our whole purpose, not just to be task driven, but to assess our patients, right? Evaluate them, look for signs and symptoms and cues. Here are some interventions. Why do you avoid heating pads? Why should I always wear socks when walking? Decrease sensation, okay? Here are goals of care. Okay, this came from American Diabetes Association. SMART goals. You should understand SMART goals already. But with your patients, set SMART goals, especially if they're newly diagnosed.